afternoon. Today we're going to discuss electrolyte imbalances related to potassium, magnesium, calcium, and phosphorus. Let's start talking about potassium deficits. You know that potassium is the most abundant intracellular cation, but only about 2% of the total body potassium is extracellularly. If you remember in pathophysiology, potassium has the advantages to pass through the membrane freely, even though when it shifts with sodium, it requires energy through the sodium-potassium pump. So because of that, potassium leaves the intracellular space negatively charged and the extracellular space positively charged due to the higher concentration of sodium. And that is the normal polarity of the resting membrane. Because most intracellular potassium is contained within muscle cells, total body potassium is roughly proportional to lean body mass. An average 70 kilogram adult has around 3,500 milliequivalents of potassium. That's the reason why it's 3.5 to 4.5 the value of potassium in plasma. Potassium is a major determinant of intracellular osmolality as well as sodium for the extracellular osmolality. The ratio between potassium concentration in the ICF and the ECF strongly influences polarization, as I told you, polarity of the resting membrane, which in turn influences important cells processes. And that includes nerve impulse and muscle contraction. So whenever you have alteration of potassium, potassium will produce muscle weakness or muscle alterations due to the action potential being impaired. In addition, myocardial contractility being impaired or increased with either bradyarrhythmias or tachyarrhythmias. In the absence of factors that shift potassium in and out of the cell, the serum potassium concentration correlates very closely with the total body potassium content. Once intracellular and extracellular concentrations are stable, a decrease in serum potassium concentration of about 1 milliequivalent per liter indicates a total potassium deficit of about 200 to 400 milliequivalents. So patients with potassium less than 3.5 typically have a significant potassium deficit. Normally, how does potassium shift? So you would understand the reason why these are the most common causes of potassium alteration. Potassium shift in and out of the cell due to insulin concentration. If you remember, insulin brings potassium inside the cell. So if you have an hyperinsulinemia, the patient would have hypokalemia. The same way backwards. If you have a patient with diabetes type 1 with its insulin insufficient, the insulin will not be able to bring the potassium inside the cell. Therefore, patients will be hyperkalemic. Beta-adrenergic activity, which is bronchodilator therapy, also could do that, especially selective beta-2 agonists. They move potassium into the cell. The contrary, beta blockers and alpha agonists promote movement of potassium out of the cell. You know that metabolic imbalances will produce the same as well. Acute metabolic acidosis causes potassium to move out of the cell, whereas acute metabolic alkalosis causes potassium to move inside of the cell. However, changes in serum bicarbonate concentration may be more important than changes in pH. Acidosis caused by accumulation of non-anion gap or hyperchloremic acidosis is more likely to elevate serum potassium. So the patients that have non-responsive hyperchloremic acidosis would have more hypokalemia than patients that have high anion gap metabolic acidosis, even though this is mediated by lactate. When the tissue is impaired of oxygen and volume, there is lactate released and muscle damaged because of cell death. Therefore, potassium also leaves the cell. But the non-anion gap is more relevant than the anion gap. In contrast, metabolic acidosis due to accumulation of organic acid, as I just mentioned, with increased anion gap acidosis, does cause hyperkalemia, but less than non-anion gap, even though it seems to be the opposite. Does the hyperkalemia common in diabetes ketoacidosis, for example, results from insulin deficiency than from acidosis? Another example is acute respiratory acidosis and alkalosis. That affects serum potassium concentration, but less than metabolic acidosis and alkalosis. Nonetheless, serum potassium concentration should always be interpreted in the context of serum pH and as well as bicarbonate concentration. So, what about false concentration of potassium? Pseudo hypokalemia or pseudo hyperkalemia, which is basically false low serum potassium or false high serum potassium, occasionally is found when blood specimens from patients with chronic myelocytic leukemia, for example, that specimen remains in room temperature. The same thing happens when the patients have elevated WBC, and that blood remains in room temperature before being processed because of uptake of serum potassium by abnormal leukocytes in the sample. It is prevented by prompt separation of plasma or serum in blood samples. So if you spin the blood quickly in the centrifugage, that should not happen. In addition, pseudo hyperkalemia or falsely elevated serum potassium is more commonly typically due to hemolysis. When you put a very tight tourniquet through phlebotomy, that could happen because it releases potassium from the intracellular space to the extracellular space. So to prevent false results, phlebotomy personnel should not rapidly aspirate blood through a narrow gauge needle or excessively agitate blood samples or leave a prolonged tourniquet placed once you basically obtain, once you stick the patient and obtain blood return, you should release the tourniquet to avoid hemolysis. Pseudo hyperkalemia can also result from a platelet count of more than 400,000. So when the patients are thrombocytosis due to release of potassium from platelets during clotting, that could happen. So in cases with pseudo hyperkalemia, the plasma potassium of unclotted blood as opposed to serum potassium is normal. So that means that patients with pseudo hyperkalemia have a falsely low or falsely high potassium result due to other factors not related to a real potassium imbalance. Now, how is potassium metabolized before we go into the imbalances? Remember that potassium is obtained by diet and is excreted mainly by the kidney. So if the patient is not obtaining good sources of potassium through the diet, patients would have imbalance of potassium, and if the patient has impaired renal excretion, patients would have alterations in the metabolism and of course imbalances of potassium, most likely related to hyperkalemia. So dietary potassium intake normally varies between 40 to 150 milliequivalents per day. In a steady state, fecal losses are usually close to 10% only. The majority of the excretion of potassium, which is 90%, is through the urine. So any alteration in renal will alter also the potassium concentration in plasma. When potassium intake is greater than 150 or about 50% of the excess potassium that the kidney could handle, this could also elevate the potassium. So most of the remaining is transferred into the intracellular compartment, thus minimizing the rise in the serum potassium. When elevated potassium intake continues, aldosterone secretion is stimulated, and those renal potassium excretion rises. The excretion is the one that increases, because remember, the function of aldosterone is reabsorption of sodium and water and excretion of potassium. So the autoregulation mechanism is, once you have increased intake or decreased output of potassium, aldosterone is released to be able to reabsorb sodium and water and excrete potassium. In addition, potassium absorption from stool appears to be under some regulation and may fall by 50% in chronic potassium excess. When potassium intake falls, intracellular potassium again serves to buffer wide swings in serum potassium concentration. So renal potassium conservation develops relatively slow in response to decrease in dietary potassium, and is far less efficient than the kidney's ability to conserve sodium. So those potassium depletion is a frequently clinical problem. Urinary potassium excretion of 10 milliequivalents per day represents near maximal renal conservation and implies significant potassium depletion. Acute acidosis impairs potassium excretion through the kidney, whereas chronic acidosis and acute alkalosis can promote potassium excretion. So that's the reason why when the patients have metabolic acidosis, they have hyperkalemia, and when they have metabolic alkalosis, they have hypokalemia. Increased delivery of sodium to the distal nephron, as occurred with hypernatremia or high sodium intake, or when you give loop diuretics therapy to a patient, that promotes potassium excretion. Remember that I said in class that whenever you have changes in potassium value, most likely hypokalemia, that brings sodium inside of the cell, producing hyponatremia. So the reverse applies. If you have increased sodium intake, that will blunt potassium to go inside of the cell, and of course promotes excretion of potassium, producing hypokalemia. So now let's go straight to the alterations or imbalances, including hypokalemia and hyperkalemia. Okay, hypokalemia is serum potassium concentration less than 3.5, basically caused by a deficit in total potassium stores or abnormal movement of potassium inside of the cell. As I said, either you're not ingesting a properly amount of potassium, or you're not excreting proper amount of potassium due to kidney problems. The most common causes are excess loss from the kidney or the GI tract. So the etiology of hypokalemia can be caused by decreased intake of potassium, but is usually caused by excessive losses of potassium in the urine or from the GI tract. So let's start with GI tract, which is the most common cause. So if you have diarrhea, chronic of course, or you are in a chronic laxative use, if, for example, you're vomiting, if you have protracted gastric suctioning, with an NG tube, or rarely if you have a tumor which, in the colon, which causes massive potassium secretion, those could be causes of GI or non-renal related causes. In addition, hyperaldosteronism also belongs to a non-renal potassium loss. Again, if you remember, the function of aldosterone is reabsorption of sodium and water and excretion of potassium. So if the aldosterone level is elevated, then potassium loss will be increased. Another one will be sweating, that is non-related to renal causes. So GI potassium losses may be compounded by concomitant renal potassium losses due to metabolic alkalosis and stimulation of aldosterone due to volume depletion. So remember that every time you have a volume depletion, the autoregulation mechanism is the catecholamine release, renin-angiotensin-aldosterone system. So every time you have a situation that the patient is hypovolemic, aldosterone will be increasing, so therefore potassium would be decreasing. Another cause is transcellular shift or intracellular shift of potassium into the cell. That may also cause a hypokalemia, and the most common causes are alkalemia. In addition, insulin and catecholamine release. I explained the movement of potassium through metabolic alkalosis, and I also explained the movement of potassium inside of the cell by insulin release. Remember that the main function of the insulin is bring the potassium inside of the cell as well as to bring the glucose inside of the cell for the metabolism of the cell. In addition, glycogenesis during TPN or enteral hyperalimentation also stimulates insulin release. So every time you nourish the cell, insulin will be released by the beta cells of the pancreas. Administration of insulin itself when you're giving insulin to the patient. If you remember, I also mentioned the sympathetic nervous system stimulation by catecholamine release, not only when the patient is under stress, but also when the patients are administered beta-2 agonists, such as albuterol or terbutaline. The albuterol or levoalbuterol. In addition to that, another way of catecholamine release is thyrotoxicosis. If you remember in endocrine, patients when have hyperthyroidism, they release excessive amount of beta sympathetic stimulation. So that produces hypokalemic thyrotoxic period. Renal losses. We have various disorders that can increase potassium excretion. One of them is excess of mineralocorticoid. If you remember, the main mineralocorticoid secreted by the adrenal gland is the aldosterone. So having hyperaldosteronism, I already explained, that is the main cause of sodium and water reabsorption and potassium excretion. In addition, adrenal steroid excess. So if the patient has Cushing's syndrome, the patient will be releasing high levels of cortisol in addition to high levels of aldosterone. So the same function happen, reabsorption of sodium and water and excretion of potassium. In addition, if the patient has renin secreting tumors, remember that renin stimulates angiotensin for ACE to convert into angiotensin 2 and for the release of aldosterone. So the whole cascade of events happen, and reabsorption of water and sodium and excretion of potassium will take place. In addition, Bartter syndrome, which is no more than a congenital disorder that provide mineralocorticoid excess. The same happens with Little syndrome, which is another congenital disorder of increased release of aldosterone. So basically, it's an autosomal dominant disorder characterized by hypertension and hypokalemia. Basically, it's caused by unrestrained sodium reabsorption in the distal nephron due to a lot of mutations at the level of the epithelial sodium channel. And there is inappropriately high reabsorption of sodium results in hypertension and renal potassium wasting by aldosterone. Another one would be renal tubular acidosis, which, if you remember, this is the most common cause of intrarenal renal failure. So whenever, and basically is due to a prolonged hypovolemic state or a prolonged not improvement of pre-renal renal failure, which is due to hypovolemia. And whenever you have hypovolemia, even before you have cortical damage of the nephron, patients would have release of renin and angiotensin 1, angiotensin 2, and aldosterone. So all that will fall into the categories of hyperaldosteronism. Diuretics are by far the most commonly used drugs that cause hypokalemia. You have the potassium wasting diuretics that block sodium reabsorption either proximally or distally or at the level of the loop of Henle. And if you remember, you have the thiazide diuretics, you have the loop diuretics, and you have the osmotic diuretics that basically work at the level of the proximal tubule. So by inducing diuresis, you could provoke hypokalemia as well as by inducing diarrhea with laxative. You could also have hypokalemia. There are many more examples of or causes of hypokalemia, and that could include drugs that are given, for example, for fungal infections such as amphotericin B, many antibiotics such as anti-pseudomonal penicillins, or theophylline as well. Every time you accelerate the catecholamine release, you could produce hypokalemia. So what about the clinical presentation or the clinical signs and symptoms that the patient will have? So basically, it could go from mild hypokalemia to severe hypokalemia. Mild hypokalemia is basically a serum potassium level less than 3.5. Generally cause muscle weakness, and when once advances, of course, to the moderate to severe hypokalemia, may lead to paralysis and respiratory failure. Other muscular dysfunctions could include cramping, fasciculations, ileus paralyticus, hypoventilation, hypotension, up to even tetany and rhabdomyolysis. That, of course, once you have rhabdomyolysis, by prolonged paralysis of the muscles, that could stimulate hyperkalemia after all. So remember that a muscle weakness, every single muscle, every single skeletal muscle of your body, including the muscles of the respiratory tract, because you have the escalens, you have the intercostals, you have the diaphragm. If those muscles are weakened, patients would have hypoventilation, and they could have respiratory failure due to hypoventilation syndrome. So therefore, not only they would have hypokalemia, but they could retain CO2 with respiratory acidosis. In addition, patients have impaired renal concentrating ability, so they could have polyuria and polydipsia secondary to a large amount of urine output. Now, how do you diagnose hypokalemia? Basically by serum potassium measurement and by EKG. And when the mechanism is not evident, you could do a 24-hour urine collection of potassium and serum magnesium. And why magnesium? Because magnesium is necessary as a cofactor for the sodium potassium pump. So if you have hypomagnesemia, you better correct the magnesium first before you continue giving a large amount of potassium that is not going to be brought inside the cell. So hypokalemia, remember that serum potassium is normally 3.5 to 4.5. So if it's less than 3.5, you are in hypokalemia. So what would be the diagnosis evaluation? Clinical signs and symptoms already mentioned, and also EKG. The cardiac effects of hypokalemia are usually minimal until serum potassium concentrations are less than 3. So hypokalemia causes sagging of the ST segment, and if you were with me in assessment or pathophysiology, remember that if you take the EKG with both of your hands and you stretch the EKG, you will obtain depression and even inversion and flattening of the segments and intervals. So you would have as well depression of the T wave. And in addition, with marked hypokalemia, the T wave could become progressively smaller, and sometimes flat or positive U wave could appear. QT prolongation also, if the patients would have any type of arrhythmias, it would be bradyarrhythmias. So the patients are very highly at risk of second and third degree AV blocks. And here you have the EKG changes that are present in hypokalemia. And the more it advances, remember, you have flattening of the PR interval and the QT interval as well, flattening of the T wave until it becomes inverse. You have a prominent U wave, and then the opposite could happen. You have the hyperkalemia here that I also have another presentation for hyperkalemia. So again, this is the diagnostic evaluation of choice. Now, these again are the signs and symptoms of hypokalemia. The patients would have hyporeflexia, muscle weakness, shallow respirations, the pulse will be weak, and as well as arrhythmias will be mostly bradyarrhythmias. Patients could go up to altered mental status of lethargy and confusion. They would have hypoactivity, EKG changes as already mentioned. Now, treatment-wise, you could administer, if the patient has the GI tract intact and there's no vomiting, patients could obtain oral potassium supplement. Otherwise, if it's severe hypokalemia, IV, or if the patient, of course, cannot use the GI tract. So many oral potassium supplements are available because high single doses can cause GI irritation and occasional bleeding. Deficits are usually replaced in divided doses. So liquid potassium chloride given orally elevates concentration within 1 to 2 hours, but has a bitter taste and is tolerated particularly poorly in doses greater than 25 or 50 milliequivalents. So waxy impregnated potassium chloride, the ones that are not liquid, are best tolerated by the GI tract. They're microencapsulated potassium preparations. So several of these preparations contain from 10 milliequivalents on. Because a decrease in serum potassium of 1 milliequivalent per liter correlates with about of approximately 200 to 400 milliequivalents deficit in the total body potassium stores, total deficit can be estimated and replaced over a number of days at 20 to 80 milliequivalents per day. Now, normally the choice is to administer 10 milliequivalents for each 0.10 milliequivalents per liter decrement in serum potassium. So if you have, for example, a serum potassium normally is 3.5 and you have 3.2 or 3.0, you could give 10 milliequivalents. If you want to give 20 milliequivalents, try to separate that in a 8 to 12 hours interval. When hypokalemia is severe, or even if it's not less than 2, but patient has EKG changes, that is also showing severe symptoms. Or if the patient is unresponsive to oral therapy, you could provide IV potassium. Now, remember that hypokalemia in patients that are taking digoxin have significant heart disease or ongoing potassium losses that could provoke, or patient could be at risk of digoxin toxicity. So it's very important when the patient are on digoxin to replace potassium appropriately, because otherwise the patients could have toxicity. Because potassium solutions can irritate peripheral veins, the concentration should not exceed 40 milliequivalents per liter. The rate correction of hypokalemia is limited because of the lack in potassium movement into the cell. So routine infusion rates should not exceed 10 milliequivalents per hour when you're using a peripheral line. In hypokalemic induced arrhythmias, IV potassium chloride must be given more rapidly and also at higher dosages. Infusion of 40 milliequivalents of potassium chloride per hour can be undertaken, but only with continuous cardiac monitoring and hourly serum potassium determination. So it's better to be safe and give 20 milliequivalents through the central line every 8 hours than to be monitoring so closely the potassium. Glucose solutions are avoided because of elevation in serum insulin, which brings the potassium inside the cell even more. Even when potassium deficits are severe, it is rarely necessary to give 100 to 120 milliequivalents of potassium in a 24-hour period unless potassium losses continues, even though this is the guideline. In potassium deficit with high serum potassium concentration, as is present in patients that have diabetes, ketoacidosis, IV potassium is deferred until the serum potassium starts to fall, and also when the patient urinates. Never, never, never give potassium solutions if the patient is anuric or oliguric. Once the urine output is improved by IV fluids, if the patient is hypovolemic, then you start potassium replacement, because remember, 90% of potassium excretion is through the kidney. Now we'll come back here to hypokalemia. So let's introduce hypokalemia first, and then we go back to the actual symptoms. Now hypokalemia is serum potassium concentration of more than 5.5, and most likely results from an excess of total body potassium stores or abnormal movement of potassium out of the cell. There are usually several simultaneous contribution factors, and that includes everything backwards from the hypokalemia. Increased potassium intake, impair renal potassium excretion, acute or chronic kidney disease, metabolic acidosis that also includes diabetes, ketoacidosis. The most common cause of increased serum potassium is probably pseudo hyperkalemia, caused by hemolysis of RBCs in a blood sample. Remember that normal kidneys eventually excrete potassium loads. So sustained non-artifactual hyperkalemia usually implies diminished renal potassium excretion. However, other factors usually contribute. They can include increased potassium intake, increased potassium release from the cell by damage or hemolysis. Normally, when sufficient potassium chloride is ingested or given parenterally, severe hypokalemia may result even when renal function is normal. So if you are basically treating the patient with hypokalemia, you could obtain the opposite, which is hyperkalemia. Now, going through the causes again, if you do not have a proper renal excretion, orally, if you have a high oral potassium supplement, transfusion. Transfusion is another contributing mechanism. So basically you have them all here. IV fluids with supplemental potassium. So now if you decide to put the patient on half normal saline or D5, half normal saline with 20 milliequivalents of potassium, and there are other contributing factors that could increase potassium, you could have hyperkalemia. TPN as well could produce hyperkalemia. So if elevated insulin or giving insulin to the patient could provoke hypokalemia, so deficiency of insulin could provoke hyperkalemia. If beta-adrenergic agonists such as beta agonist albuterol, levobuterol, or terbutaline, or even theophylline could produce hypokalemia, the contrary is for hyperkalemia. So patients with beta blockers will have increased potassium movement out of the cell. Digoxin toxicity, even though the most common factor to produce digoxin toxicity is hypokalemia, the actual toxicity of digoxin itself could produce damage to the cell and produce lysis and release potassium. Another one that you already studied in prior semesters is acute tumor lysis syndrome. That produces hyperphosphatemia and hyperkalemia, if you recall. So any type of hemolytic syndrome such as sickle cell disease or spherocytosis could produce hypokalemia. Bleeding disorders in the GI tract, burns, rhabdomyolysis. As I said, diabetes mellitus type 1, which is insulin deficiency. In addition, extraneous exercise could produce damage to the cell and release potassium. Metabolic acidosis. What about drugs? You need to remember, and this cannot be forgiven, ACE inhibitors. If angiotensin converting enzyme will release angiotensin 2 and as well as aldosterone, and the function of aldosterone is retention of sodium and water and excretion of potassium, hyperaldosteronism will give you hypokalemia, but ACE inhibitors will not be able to release aldosterone, so therefore deficiency of aldosterone would give you hyperkalemia. The same applies for the ARBs. In addition, heparin. Heparin is an aldosterone antagonist. So patients that are on heparin drips, less likely with subcute, but patients with heparin drips could also have hyperkalemia because heparin is an aldosterone antagonist. What about potassium sparing diuretics such as spironolactone, lithium, NSAIDs? So patients that are on COX-1 or COX-2, which are non-steroidal anti-inflammatory drugs, if you remember, those are located in the postrenal arteriole. So if you block the postrenal arteriole, which you're blocking the prostaglandin, you're not going to secrete proper amount of not only ADH, but no aldosterone. So if you have low aldosterone level, you would have hyperkalemia. In addition, hyperaldosteronism by adrenal insufficiency, hypoaldosteronism by adrenal insufficiency. In addition, patients that have renal failure, renal tubular acidosis, etc. So usually hypokalemia is asymptomatic unless cardiac toxicity develops. And which would be the symptoms? Basically, muscle weakness, the same as in hypokalemia, although flaccid paralysis occasionally occur. Hyperkalemia is usually asymptomatic. So periodic paralysis, weakness, and even frank paralysis could be progressing too. Diagnosis evaluation is basically by serum potassium measurement, by EKG, by reviewing drug use is very important. Remember your ACE inhibitors, remember your ARB, remember your heparin. So in addition, assessment of renal function, because the excretion of potassium is through the kidney. So if you have renal failure, patients will be having hyperkalemia. So that may be found in a routine serum electrolyte measurement, which is your CMP or BMP. Review also the potassium sparing diuretics. Patients that are mostly on advanced heart failure or urinary obstruction, or patients that have hypertension. So every time a patient comes with a hyperkalemia and they are on ACE inhibitors or potassium sparing diuretic, you should hold or change the medications to another. EKG wise, that should be done on patients with hyperkalemia, because remember, this could change the action potential, and the membrane could be more labile for firing. So it's frequently visible, these changes when the potassium is more than 5.5. So it produces conduction problems by increasing PR interval. So basically you take the EKG and you shorten the EKG instead of stretching it with your hands. So you would have an increased PR interval, shortening of the QT interval, as well as tall, symmetric, peak T wave. Potassium more than 6.5 is when you basically see the opposite, because you stretch, but as it progresses and gets worse, then conduction could be slower, with widening of the QRS and disappearance of the P wave. And there is also nodal scape and ventricular arrhythmias. And these arrhythmias tend to be tachyarrhythmias or Y complexes arrhythmias. That could include asystoles up to ventricular fibrillation. These are the causes, again. In addition, diet, which I forgot to mention, dried fruits, nuts, tomatoes, potatoes, spinach, bananas, oranges. Okay, these are another representation of the causes and the signs and symptoms. This is the EKG for hypokalemia and hyperkalemia. So remember, you have peak T waves and shortening of the PR interval, but as it progresses, there is flattening of the P, there is widening of the QRS, and also there is inversion of the T and appearance of prominent U wave. So you don't want this. Once the patient is at this level, there is an impending ventricular fibrillation or asystole. So before we go into that, let's go back and do the treatment. So the treatment has to be, first, look at the medications, treat the underlying cause. For mild hyperkalemia, you could give the sodium polystyrene sulfonate, which is your kayaksalate. For moderate or severe hypokalemia, remember that there is an alteration of the action potential, so the membrane is depolarizing, so you must give IV insulin and glucose. And the reason is to bring the potassium inside the cell with the use of insulin. And because insulin also brings glucose inside of the cell, patients would become hypoglycemic, so you must give glucose with it. In addition, to be able to avoid hyperdepolarization, you give IV calcium solution, and you could also, of course, give calcium gluconate or phosphate or oxalate, but it's better to use calcium gluconate to avoid depolarization. So the calcium gluconate does not do anything to the concentration of potassium. The only thing that it does is to decrease the umbral for depolarization and having fatal arrhythmias. Adjuvants to treatment, you could give sodium bicarbonate, you could give beta-adrenergic, because remember, the beta 2, which are albuterol and levobuterol, are factors that bring potassium inside the cell. So you're not going to treat a very high potassium with only bronchodilator therapy, but this is an adjuvant of treatment. And as an emergency as well, you could do dialysis. So for mild hyperkalemia, patients with serum potassium less than 6 and no EKG abnormalities, they may respond to diminished potassium intake or stopping potassium elevating drug only. So the addition of loop diuretics, if the patient is hypervolemic, for example, enhances the renal potassium excretion as well as the volume excess. You could give for mild hypokalemia as well the kayaksalate that is mixed in sorbitol, and that could be given 15 to 30 grams in 30 to 70 ml of 70% sorbitol, and that could be given PO Q4 to 6 hours. So again, 15 to 30 grams of kayaksalate orally Q4 to 6 hours. It asked, the action of kayaksalate is basically a cation that exchanges resin and removes potassium through the GI mucosa. This is, remember, The GI tract is only 10% of excretion, so you have to have a mild hypokalemia in order to use kayaksilate. Sorbitol is added to it because it's a resin to ensure laxative use. In addition, sorbitol, if you remember, that shift the sodium is one of the causes of hyponatremia with hyperosmolality. So bringing the sodium inside of the cell will also correct the potassium imbalance. Patients unable to take drugs orally because they have either nausea or vomiting, you could use the kayaksilate through enema. They're not as effective as the GI tract, but it's a method of use. Normally about 1 milliequivalent of potassium is removed per gram of resin that you use. Okay, so basically you calculate you're giving 15 to 30 grams for every 1 milliequivalent of potassium that you're trying to remove is basically per gram of resin. So every time you give a gram of kayaksilate, you're basically removing 1 milliequivalent of potassium. It's very slow and often fails to lower the serum potassium significantly in patients that are hypercatabolic. So because sodium is in exchange for potassium, when sodium polystyrene sulfonate, which is the name of kayaksilate, is used, sodium overload may occur, particularly in oliguric patients with pre-existing volume overload. So you have to be very careful when you use this for patients that are in CHF or any type of volume overload. When you have moderate to severe hypokalemia, and that happens in patients that have potassium between 6 and 6.5 milliequivalents, that needs prompt attention. This is an emergency because you could have cardiac arrhythmias. But the actual treatment depends on the clinical situation. If no EKG changes are present and renal function is intact, remember you need to have into account the kidney. Maneuvers of mild hyperkalemia are usually effective. So you could do the same if you have no EKG changes. Follow-up serum potassium measurements are as needed to ensure the hyperkalemia has been successfully treated. So don't treat and just leave. If potassium is greater than 6.5, more aggressive therapy is required. So you could administer regular insulin of 5 to 10 units IV, and that would be followed by 50% of glucose and 50 mL. So infusion of 50 mL of 50% of glucose. You could also use infusion of 10% dextrose when the patients are severe hypoglycemic. And again, the effect of serum potassium peaks in 1 hour and lasts for several hours. Now, if you have EKG changes, including P-wave or widening of the QRS or peak Ts, you need to give treatment with IV calcium as well as insulin and glucose that is indicated. So 10 to 20 mL of 10% of calcium gluconate is given over 5 to 10 minutes. Basically what happens is that calcium antagonizes the effect of hyperkalemia on the cardiac muscle. Calcium should be given with caution in patients that are in digoxin because of the risk of precipitating hypokalemia-related arrhythmias, as I said. If the EKG shows signs of ventricular fibrillation or asystole besides your ACLS protocol, calcium gluconate may be given more rapidly in the co-response, and it would be done in 5 to 10 mL IV over 2 minutes instead of over 5 to 10 minutes. Calcium chloride could also be used, but remember that besides irritating the peripheral vein and causing necrosis if this extravasates, you have to be very careful if the patient is in metabolic acidosis because of the chloride component, and should only be given through central line. Okay. In addition, as I said, you could give adjuvants to treatment with albuterol You could give 10 to 20 milligrams inhale over 10 minutes, and that normally lowers the serum potassium concentration by 0.5 to 1.5. So it's not a big deal, but it's a good adjuvant. Another adjuvant is administration of IV sodium bicarbonate, but that is controversial because remember that it reduces from alkalinization or the hypertonicity due to the concentrated sodium in the preparation that shift sodium. The hypertonic sodium that contains may be harmful for patients that are in volume overload or CHF, patients that are in renal failure, end stage, in dialysis, for example. So you have to be very careful because remember that sodium bicarbonate not only produces a metabolic acidosis that is good to shift the potassium inside the cell, but also could produce volume overload states by sodium, pulmonary edema, volume overload in renal failure patients, CHF patients, etc. Okay. Dialysis should be considered early in patients with end-stage renal disease or in an emergency as well as a coadjuvant of treatment. There are highly increased patients that are in end-stage renal disease of severe hypokalemia and serious cardiac arrhythmias. You could also use peritoneal dialysis to remove the potassium out of the cell. Now let's talk quickly about calcium. Remember that calcium has an inverse relationship with phosphorus. So the signs and symptoms of hypercalcemia would be for the hypophosphatemia, and the signs and symptoms of hypocalcemia will be for hyperphosphatemia. So calcium. First, calcium is basically required for the proper function of the muscle contraction, for nerve conduction, and remember that calcium is necessary for muscle contraction, nerve conduction, hormone release, and also blood coagulation. Calcium participates in the coagulation cascade. In addition, you have hormonal influx related to calcium metabolism, and this is PTH. The parathyroid hormone, if you recall, produces a reabsorption of calcium and excretion of phosphorus at the level of the intestine, the kidney, and the bone. And the opposite will be for calcitonin. So both extracellular and intracellular potassium concentration are tightly regulated by bidirectional calcium transport across the plasma membrane. So endothelial reticulum and sarcoplasmic reticulum of the muscles needs calcium for muscle contraction, mostly in excitation contraction that happens at the level of the cardiac and the smooth muscle. So basically calcium is an intracellular messenger for muscle contraction. So the normal levels are 8.8 to 10.4, or in another way of presentation is one is in milligram per deciliter and the other one is millismol per liter, 2.2 to 2.6. Ideally, remember that you need to try to measure calcium in ionized or free calcium. Calcium needs a passive medium of transportation through the membrane. So calcium is attached to proteins, which in this case is albumin. So any changes in albumin concentration or the nourishment, the nutrition status of the patient could affect the total calcium in plasma. So whenever you are going to measure and pay attention to calcium imbalances, you must pay attention to the levels of albumin and try to correct the calcium level by a formula that I will provide. So ionized or free calcium is the one that should be determined because of the attachment of the calcium to the albumin, and it's necessary because of the medium of transportation, which is passive mediated transportation through the membrane. So normally the normal calcium concentration is 8.4 to 10.3, and the ionized calcium is 4.2 to 5.2. And this is the formula that you should know when you want to correct calcium. So it's calcium plus 0.8 times 4 minus the level of albumin. So albumin has to be taken into account in order for you to say that this is a real hypo or hypercalcemia. So now let's talk about hypocalcemia. Hypocalcemia is total serum calcium concentration of less than 8.8 or less than 8.4 or less than 2.2. In the presence of normal plasma protein concentration, or a serum ionized calcium of less than 4.7 or less than 1.17, or in some books, as I said, less than 4.2 or less than 8.4. Now, the main causes. The causes of hypocalcemia include hypoparathyroidism. If you remember, the parathyroid gland is in charge of reabsorption of calcium at the level of the intestine, the kidney, and the bone. So reabsorption means that if the PTH is in charge of that function, reabsorption means more of the electrolyte in plasma. So you're going to have normal levels if you reabsorb. If you're unable to reabsorb because you have hypoparathyroidism, so meaning low PTH level, you're not going to be able to absorb properly. Vitamin D deficiency, because it's necessary for the metabolism of calcium and the action of PTH, and also renal diseases. Remember that PTH acts at the level of the kidney for reabsorption of calcium as well. So therefore, if the patient has renal failure, they're not going to be able to reabsorb proper calcium at the level of the kidney, even if the PTH level is within normal limits. So hypoparathyroidism is characterized by hypocalcemia, and whenever you have the calcium level low, you're going to have high phosphorus, because what's the function of PTH? Reabsorption of calcium at the level of the intestine, kidney, and bone, and excretion of phosphate. So if you have low PTH, if you have low vitamin D, if you have renal problems, you're not going to be able to reabsorb, so you're going to have low calcium and high phosphate. So hypoparathyroidism results from deficiency of PTH, which can occur in an autoimmune disorder or after accidental removal of the parathyroid gland during thyroidectomy. Remember that this is a iatrogenic disease. Transient hypoparathyroidism is also common after subtotal thyroidectomy, and this is again a problem that many surgeons experience. Manifestations of hypocalcemia usually begin about 24 to 48 hours postoperatively. This is the reason why whenever the patient has thyroid surgery, because of the possibility of iatrogenically removing the parathyroid hormone, the patients must be in ICU, being monitored for 48 hours. PTH deficiency is more common after radical thyroidectomy for cancers, and as a result of removal of parathyroid hormone iatrogenically, as I said, due to thyroid gland removal or a nodule. In addition, you have a pseudo hypoparathyroidism, which is an uncommon group of disorders that is characterized when you have a hormone deficiency by genetic transmission. In addition, vitamin D deficiency and dependency are were discussed before when I said that vitamin D is necessary for the metabolism of calcium through the PTH. So in addition, when the patients have uh, decrease exposure to sunlight. They could be vitamin D deficient. In addition, patients, when they have hepatobiliary disease or intestinal malabsorption, since remember PTH act at the level of the intestine with the help or adjuvant help of vitamin D metabolism. In addition, drugs that could affect the vitamin D metabolism are the anti-seizure medications such as phenytoin and phenobarbital. Aging could produce skin changes that could affect vitamin D. Um, in addition, patients that have transfusion with citrate, patients that are in CRRT, renal tubular acidosis could also produce hypocalcemia. Um, Other causes, magnesium. Magnesium is everywhere. If you have hypokalemia, you could have hypomagnesemia. If you have hypocalcemia, you could have hypomagnesemia. So make sure you correct or measure the magnesium level when you have this type of electrolyte imbalances. Other causes, inflammatory diseases such as acute pancreatitis. Um, Basically, what happens is that cytokine will chelate the calcium and deplete the calcium level. Hypoproteinemia, also remember that protein albumin is bounded as a fraction to calcium to bring it inside of the cell with passive mediated transport. So if you have low levels of albumin, you could have a mislead interpretation of calcium. Patients that have bone disorders, remember that the PTH act at the level of the bone to reabsorb calcium. So having major osteoporosis or bone cancer, multiple myelomas could produce hypocalcemia. Septic shock due to suppression of PTH release and the decreased conversion of vitamin D when the patients are in sepsis could also produce hypocalcemia. Hyperphosphatemia, since they're in inverse relationship, could do this. Transfusion of more than 10 units of citrate, anticoagulated blood. Use of contrast agents could also produce hypocalcemia, but they're less prevalent. Okay, so you have all the causes here. Now, clinical presentation is frequently asymptomatic, but the presence of hypoparathyroidism is basically suggests short stature or round faces or intellectual disability. It could be suspected that the patient has hypocalcemia. So major clinical manifestations of hypocalcemia are due to disturbance in the potential membrane, resulting for neuromuscular irritability. So patients would have paresthesias of the lip. They could have tongue, fingers, paresthesias as well, because remember, participates in the conduction. They could have carpal pedal spasm with prolonged and it could be painful as well. They could have muscle weakness and aching. They could have spasm of the facial musculature. Neurological wise, they could have diffuse encephalopathies, dementia, depression, up to tetany. That's the one that you mostly remember due to neuromuscular irritability. And in health assessment, we went through the Shostak and Trousseau signs that are present in that could be elicited at the bedside to identify latent tetany or hypocalcemia. Remember that Shostak sign is an involuntary twitching of the facial muscles elicited by a tapping of the facial nerve. And the Trousseau is when you have the spasm precipitated by when you take the blood pressure and you put the tourniquet and you inflate 20 millimeters of mercury above systolic, and the patients would have these carpal pedal spasm. Other signs could be alkalosis, hypokalemia, hypomagnesemia. Other manifestations, patients could have dry skin, brittle nails, coarse hair, and also candida infections. Now the treatment, well, first diagnosis. How do you diagnose that? Remember, you need to estimate and calculate ionized calcium before you say this patient truly has hypocalcemia. And the treatment is based on first check the phosphorus and check the magnesium level. You don't want to treat if you don't have a very well calculated calcium ionized, and if you don't know the values of magnesium first and phosphorus. Now, it's based on IV calcium gluconate or chloride, but remember, chloride is mostly dangerous when the patients have acidosis, for example in sepsis. You could give oral calcium for postoperative hypoparathyroidism, and oral calcium and vitamin D for patients that have chronic hypocalcemia. So what do you do for tetany? Patients that are in tetany or have Trousseau or Shofstick signs, calcium gluconate, you give 10 mL of 10% IV solution over 10 minutes. The response can be dramatic, but may last for only a few hours. You could repeat the boluses. In addition to that, infusions of calcium, remember that could be dangerous in patients receiving digoxin. The same applies for patients that have potassium imbalance. When tetany is associated with hypomagnesemia, it may respond to replacing magnesium first. So you could give 10% magnesium sulfate, which is basically a gram in 10 mL IV solution. Or you could give orally, but if the patient is in tetany, don't give it orally. That's only for replacement to avoid low calcium level or avoid low potassium level. In addition, you could provide oral calcium of 1 to 2 grams of calcium per day. You could give calcium gluconate, you could give calcium carbonate. In addition, you could provide vitamin D, which is ergocalciferol, 400 to 1,000 units per day, and you could also give calcitriol. Now let's talk about the opposite, which is hypercalcemia. Now hypercalcemia, if hypocalcemia occur in hypoparathyroidism, this one will occur in hyperparathyroidism. So basically is usually results from excessive bone resorption when you have osteoclast being activated. And the pathophysiology is, again, primary hyperparathyroidism is generally a disorder resulting from excessive secretion of PTH, and you know the function of PTH already, so probably is the most common cause of hypercalcemia, particularly among patients who are not hospitalized. Incidence increases with age and is higher in postmenopausal women. It could occur in familial forms as well. Remember that primary hyperparathyroidism could cause hypophosphatemia and excessive bone resorption. Although patients normally are asymptomatic, hypercalcemia is the most frequent presentation for nephrolithiasis. So patients would have urinary tract obstruction by urinary stones, particularly when hypercalciuria occurs during a long-standing hypercalcemia. Patients could have as another cause hyperthyroidism, prolonged immobilization, adrenal insufficiency, patients that have male alkali syndrome, cancer as well, vitamin D toxicity could be another one. To explain the male alkali syndrome is basically excessive amount of calcium ingested, usually as self-treatment. Elderly patients that get a lot of TOMS, for example, calcium carbonate as TOMS, or Mylanta through the antacids for dyspepsia or to prevent osteoporosis, that could result in metabolic alkalosis and hypercalcemia and renal failure. I'm sorry. So usually they're asymptomatic, but it could include symptoms such as constipation, anorexia, nausea, vomiting, abdominal pain, and even ileus paralyticus. It could be impairment of renal concentration mechanism leading to, and this is important, this is why the treatment for hypercalcemia should include IV fluids. Since calcium impairs the renal concentration mechanism, that leads to polyuria, nocturia, and polydipsia. So when the patients have elevation of serum calcium more than 12, that could cause these problems as well as emotional instability of delirium and stupor. In addition, patients could have neuromuscular symptoms that could be associated with, muscle weakness and also twitching. Severe hypercalcemia could also cause EKG changes such as shortened QT interval and tachyarrhythmias. The diagnosis is basically checking the ionized calcium concentration. You could do a chest x-ray basically to see if the patient is having any type of infectious process, because that could interfere with calcium metabolism and temporarily blunt the PTH response. You could do a BUN and creatinine. Remember, these patients tend to be dehydrated, so you must give IV fluids. Patients check the PTH, check the phosphate. Okay, so treatment wise, you should give first, without forgetting, first measure the calcium ionized, but secondly and most important, you must give IV saline. Okay, so mild hypercalcemia, which is serum calcium less than 11, in which symptoms are mild, treatment is deferred. You defer until you do the calcium ionize. After diagnosis, the underlying disorder, you must treat according to that. When symptoms are significant, treatment is aimed at lowering calcium level. You could do oral phosphate, like pamidronate or solodronate that you use for osteoporosis. You could increase the dose if there's no response. Now, another treatment that is important and is necessary is urinary calcium excretion. And the urinary calcium excretion is provoked by isotonic saline. Now, if the IV fluid is not correcting the volume, as well as if it's not promoting calcium excretion, it sounds a little contradicting, but you must promote calcium excretion through the kidney. First, hydrate the patient, because the alterations in calcium would produce a shift of fluid. But because of hypovolemia, there is acute renal insufficiency. You could also adjuvant or help with loop diuretics. So first try isotonic saline, and if this is not producing an excretion of calcium, you could help with loop diuretics. Now, 1 to 2 liters of saline is given over 2 to 4 hours. See how much dehydration these patients get, and also you're forcing calcium excretion through the kidney. Or you could give Lasix 20 to 40 milligrams IV Q2 to 4 hours as needed until the urine output is roughly 250 mLs in per hour, of course. So basically you need to maintain a very high urine output. Care must be taken to avoid volume depletion if you add the Lasix. Monitor the potassium, monitor the magnesium. When you have moderate hypercalcemia, which is the calcium more than 11.5, patient can be treated with, again, isotonic saline and loop diuretic, as is done for the mild. You could give biphosphonate, again, that inhibit osteoclastic activity, and that would be pamidronate, ibandronate, and etidronate. You could give calcitonin. Basically, it's a rapidly acting peptide hormone normally secreted in response to hypercalcemia by the C cells of the thyroid. So remember that calcitonin has the opposite effect of PTH. So you could give this 4 to 8 units in 12 hours. You could also give prednisone, 20 to 40 milligrams PO per day. You could also give calcitriol, and you could induce the excretion also by dialysis. So in severe hypercalcemia, when the calcium level is more than 18 or more than 4.5, patient has severe symptoms, you basically will induce excretion by hemodialysis. You could also give IV phosphate as well. So these are the signs and symptoms of both hypo and hypercalcemia. Now let's talk about phosphorus, and that will be the end of this presentation. So basically, phosphorus impairs intestinal absorption, and when the patients are in chronic alcohol, the absorption of phosphate will be impaired. When patients have hyperparathyroidism, when the patients have recovery phase of diabetes ketoacidosis, they could get phosphate imbalances. Acute alcoholic patients have severe burns, refeeding syndromes, TPN, or any transcellular shift such as in respiratory alkalosis. Remember that the PTH is also in charge of the metabolism of phosphorus. They reabsorb calcium at the level of intestine, kidney, and bone, and excrete phosphorus. So any type of PTH alteration and renal alteration will compromise phosphate metabolism. Now, hypophosphatemia is when the concentration is less than 2.5. And the main causes we already discussed, but the most common are alcoholism, burn, starvation, and diuretic use. In addition, it could be seen, as I said, in diabetes ketoacidosis, in TPN, in refeeding syndrome, in severe alkalosis. It could be seen in hyperparathyroidism. It could be seen in theophylline toxicity as well. Signs and symptoms usually is asymptomatic. Patients could have anorexia, muscle weakness, osteomalacia. They could also have serious neuromuscular disturbance, including seizures and coma and death. Also could be present hypoxemia, because phosphorus as well as magnesium are in charge of muscle tone. So it's very important for the patient to have normal phosphate and normal magnesium levels to avoid respiratory failure. So severe, before we go into the diagnosis, we have to measure the phosphate level and look at the most common causes, which again are diabetes, ketoacidosis, burn, refeeding syndrome, and also test the liver, because so it could suggest the liver dysfunction. Patients that have severe cirrhosis of the liver, suspecting alcoholism. So you could check that, or you could ask the patient if they're alcoholic. The majority will deny it, but you could, look at the liver enzymes to see if they're affected. Now, oral treatment. So you have to treat the underlying disorder first, and the treatment is basically reserved for patients that are symptomatic. So you could give phosphate doses of 1 gram TID with sodium or potassium phosphate. Oral sodium and potassium phosphate is poorly tolerated. Patients could obtain diarrhea. Parenteral, you give serum phosphate you give phosphate when the serum phosphate is less than 0.5. When the patients have rhabdomyolysis or hemolysis or CNS symptoms, so you give potassium phosphate or sodium phosphate, depending if the patient has potassium depletion as well, you give potassium phosphate. If the patient has sodium depletion, you give sodium phosphate. But the potassium phosphate is relatively safe when renal function is well preserved. Sodium phosphate preparations generally should be used in patients with impaired renal function, but remember that sodium brings water with it. So any patient that is in volume overload, you should avoid sodium phosphate and give potassium instead. Okay. Now, hyperphosphatemia is the last presentation, and basically is when the phosphate is more than 4.5 or more than 1.46 millimole per liter, and the causes include chronic kidney disease, hypoparathyroidism, and metabolic or respiratory acidosis. So again, if you remember the causes of hypocalcemia will be the causes of hyperphosphatemia, and if you remember the causes of hypercalcemia will be the causes of hypophosphatemia, because they have an inverse relationship. So major causes of hyperphosphatemia include when the patient have a GFR less than 30, so renal insufficiency, hypoparathyroidism, pseudo hyperkalemia, when you have elevation of, when you're treating hypophosphatemia, now you're giving excess of phosphate through IV or through orally or through enemas, or when the patient has shift of potassium, such as in diabetes, ketoacidosis, rhabdomyolysis, or overwhelming infections, as well as tumor lysis syndrome could produce hyperphosphatemia. These clinical signs and symptoms are exactly the same as hypocalcemia, and the treatment is based on corrected renal function to be able to excrete it properly. So you could give IV saline if the patient is not in volume overload. You could give phosphate restriction and phosphate binders. So the mainstay of treatment in patients with renal failure is reduction of phosphate intake, which usually is accomplished by avoiding foods that contain high amount of phosphate. Because of the possibility of aluminum-related osteomalacia, calcium carbonate and calcium acetate replaces aluminum-containing antacids. So you could give these phosphate binders, but having to account the possibility of renal impairment. Because of the possibility of excessive calcium and phosphate produced by vascular calcification in dialysis, taking calcium-containing binders or phosphate-binding ricins without calcium, such as sevelamer, is widely used in dialysis patients. You could also use Renvela or Renagel, which is sevelamer. You could use lanthanose carbonate, is another phosphate binder that lacks calcium, and is every time it lacks calcium is very benefit for dialysis patient. So this sevelamer is the best for dialysis patient. Remember that magnesium brings water with it, and everything that has aluminum is not good for kidney, and also produces constipation. Now let's talk quickly about magnesium deficiency, and we'll talk about hypomagnesemia. Basically, it's magnesium less than 1.4, and the causes are Decreased magnesium intake, absorption, or increased excretion due to hypercalcemia. Patients that are in Lasix, so any times there is impaired intestinal or renal absorption and secretion, you could have hypomagnesemia. Patients that have malnutrition, alcoholics, any malabsorption, any major renal excretion such as diuretics, drugs such as aminoglycoside and cyclosporin, and the majority of the patients are asymptomatic. So if symptoms appear, anorexia, nausea, vomiting, lethargy, weakness, patients could have the same signs and symptoms of hypocalcemia, such as Trosan Shaftik sign, carpal pedal spasm, hyperreflexia. They could have neurological manifestations as well. And the treatment is basically oral magnesium sulfate or IV. So if the patient is asymptomatic, it's best to use magnesium oxalate or slow mag. If the patient is symptomatic, you could use magnesium sulfate. So basically, in severe symptomatic hypomagnesemia, when the magnesium is less than 1 milliequivalents per liter or less than 0.5 millismol per liter, or if the patient has seizures or any major severe symptoms, you could give from 2 to 4 magnesium sulfate IV over 5 to 10 minutes. If the seizures persist, you could repeat the dose up to 10 grams over the next 6 hours. You could also have to give benzodiazepines such as lorazepam. So the treatment with magnesium salt is indicated when magnesium deficiency is symptomatic or persistent. Patients with alcoholism are treated empirically. In such cases, deficit approaching 12 to 24 milligrams per kilo are possible. So oral magnesium sulfate such as magnesium gluconate from 500 to 1000 TID are given for 3 to 4 days. And hypermagnesemia is basically iatrogenic when you're giving a lot of antacids or laxative. Patients that have renal failure, patients that have tumor lysis syndrome and DKA, the majority are asymptomatic. But remember that impairs mechanical ventilation because there is muscle weakness. If the patients would have symptoms, the majority of the symptoms would be hyporeflexia, hypotension, and respiratory depression, as well as cardiac arrest. Treatment is based on severity. So if you have severe magnesium toxicity, that consists of circulatory and respiratory support with administration of 10% calcium gluconate, 10 to 20 mL IV. You could give calcium gluconate to reverse many of the magnesium-induced changes in the respiratory muscle and the cardiac muscle. You could also give administration of IV Lasix to avoid the overload and increase magnesium excretion if the renal function is proper. You could also do hemodialysis, so you basically have to take that out quickly. Saline administration as well. And this will be the end of this presentation.